how we manage it, and what can affect those. But it's important we look at wound healing physiology first. So we got three stages, three sequential stages. So we got inflammation, migration and proliferation, and maturation. So the initial phase, the inflammatory stage, so that's when you get your coagulation factors in there, you get hemostasis of the wound, typically over the first few days after the injury. This is where we get a lot of, any sort of, anything that can prolong the inflammatory stage is when we get abnormal wound healing. So what are some things you can think of that would prolong it, like conditions people have that we worry about?
Sepsis.
Yeah, diabetes is a big one that we think about offhand. So those patients have like a pro-inflammatory stage, so we worry about wound healing in those patients. We also worry about infection too, because their immune system is compromised. So sometimes we have to prophylactically treat them with antibiotics depending on what conditions they have. Then we got our migration and proliferation, so you get the epithelialization over the incision, wound contraction. And then usually this happens in the first week or two. And then you get the final stage of maturation over weeks to months. But for any wound, 80% of the original tensile strength is reached in 6 to 8 weeks. But we never actually get, you never get 100% of your strength, tensile strength back for that wound down the road. So it never heals to 100%. But let's talk about the different closure types we like to use. So primary intention. So when we have any wound that we're evaluating, we got to look at how we're going to close it. So some of the things we look at are how deep that wound is, how dirty it is, whether we have any foreign bodies or anything in there. We also want to look at certain dog bites and other sorts of conditions. So we usually don't like to close those unless they're on the face for cosmetic reasons, just because we risk creating a pocket of infection if we're closing it up with all that bacteria in there. So for all these wounds, we got to look at whether we can close it primarily with sutures, staples, even a wound adhesive is considered a primary closure. If you're using Dermabond, does anybody ever use that? Dermabond is great, excellent, works for a lot of different things. When I grew up, my mom had this antibacterial spray, so anytime I got hurt, we hated it because it burned, and we were like, oh no. So I use Dermabond on everything with my kids because it burns. So now they avoid telling me that they have any sort of injury or they cut themselves because they know when you use it and it burns. Yeah, it's kind of like how I grew up, but it was great. So we can suture, staple, we can even do, depending on how deep the wound is, buried sutures, but primary intention is typically the preferred method that we like to use for closure. However, depending on the size of the wound, how deep, there's very little cosmetic difference, if we were to use scary strips on a lot of these wounds that we suture up, but that requires patient compliance. So we typically suture the wound. Staples work great for the scalp area or those non-cosmetic areas. And normally we like to do a primary closure within the first 8 hours. I think right now we're sitting at 18 hours is really the max when we want to do some sort of primary closure, unless it's the face, because we have, the face is highly vascular, so we can close that up to 24 hours after, plus it's a more cosmetic area as well. But those are the general rules of thumb for doing a primary closure. And then secondary intention is when we just let it heal by itself. So we can pack the wound from the bottom up and allow it to heal on its own. And it'll eventually, those healing, those 3 steps of healing we saw in the first slide. So your body will basically take care of it itself. However, it just takes a little longer than it would if we were to primary close that wound. Then we have tertiary intention, which is delayed primary closure. So that's any sort of wound that we have to continuously debride the wound will wait. Some people will require multiple surgeries on very large wounds, multiple washouts in the operating room. And after all those procedures, then we may close it, and that's where we do tertiary intention or delayed primary closure. So we just leave it open until all our procedures are complete, and then we close it. All right, so here's the wound types we're going to talk about today. We got everything: contusions, abrasion, punctures, lacs, bites, burns, envenomation, crush, extrav. which anybody have some extravasation during the IV lab? Hopefully not, but I'm sure somebody had some giant bruising and they had some extravasation of some of that saline. Then we got like high velocity and amputations. So here's a question. Somebody goes to surgery, they get their appendix out, they close the incision cleanly with sutures in the operation. How is this wound going to heal? Primary intention. I think I heard somebody else. All right, so here's our basic approach. Obviously, initially, we want to make sure, we have hemostasis of the wound. We do our primary survey, our ABCs. And then we like to do a bedside exam. We like to explore the wound for the severity of it, just to see the depth of it. Is it, how deep is it? Do we have muscle involvement? We also want to look at where the location is and how much tension is going to be on that wound, which is another reason we may or may not close it. And then we want to make sure we give them some sort of pain control or anesthesia for this. Typically, for most of these wounds, we do a local anesthesia. So this will be something like lidocaine, marcaine, and depending on where it is, like we do a lot of regional blocks, or we can do like digital blocks, which are very common. And then we want to make sure we do thorough cleansing of the wound. We typically like to use only non-toxic solutions like sterile saline, sterile water, LR, but tap water works just as well. I have most of my patients, if it's an extremity wound and they can, an upper extremity, I'm like, hey, just put it under the sink for 5 minutes, and makes it pretty easy for your irrigation of the wound, or else you're gonna have to get multiple bottles of, sterile water or saline or bags, and it takes a lot longer. So, like I said, we want to look at how deep it is. We want to look at how, wide. We also want to look at whether it's linear. Is it like stellate? Is it jagged? That's all going to help us decide whether we're going to close that wound. I got a guy cut his thumb with a chainsaw a couple weekends ago, and it was like a pretty, not extremely deep, but it did go through the skin and subcutaneous, or the epidermis, dermis, and the subcu, but it was such a strange wound I couldn't close it. I was like, I don't know how I would even close that. And I think there was some foreign body in there that I couldn't get out as well. So obviously that wasn't going to be a great closure no matter what we did. So I made sure we treated it with antibiotics and explained you may have some, a piece of debris in that wound, and I would do a lot more damage, like trying to dissect down. Especially when you have all your extensor tendons in that area where he suffered the laceration. So we always want to look at those factors as well. And then we got to think about, all right, what kind of closure can I use for this? And we'll talk about these in these slides. We got to think about, obviously the, any foreign debris or material that we're concerned might be retained in there. We need to think about treatment with antibiotics. And then whether we should close it or not is an important consideration. And then how long ago, obviously, the wound happened, because if it's over that 18-hour, 24-hour period, then we may not want to close it anyway. And then we got to think about, do they need prophylaxis or not? So obviously, any bite wounds require prophylaxis. Any sort of dirty wounds that require extensive debridement, we'll usually start them on antibiotics prophylactically. If they're diabetics, I usually consider antibiotics as well. All right, so contusions. So these are just superficial wounds. Skin is intact, and it's usually like a hematoma under the skin. So you get that bleeding under the skin. It creates that ecchymotic appearance on there. And typically, we don't do anything for these. If there's the hematoma is continuing to expand or anything, we might apply some direct pressure. If we're concerned about some sort of vessel damage under there that's continuously bleeding or causing the hematoma, then we can look at opening it up and doing some sort of vessel ligation or cauterization, and then wrapping and packing that wound. But typically, these are just normal wound mechanics, like elevate the wound above the level of the heart, apply some direct pressure on there, or some sort of bandage, and just let it heal on its own. All right, abrasions. So this is superficial damage, usually the epidermis, some of the dermis. it's not deep enough to hit like any sort of subcutaneous tissue. So these are extremely painful just because we have all those like nerve receptors in that area. So typically the concern with these, and this is like a common one, like that guy probably had some road rash, whether he was like riding a bike or motorcycle, he did something to fall on his belly and slide. You know, I don't know if your guys' feeds are filled with just like people dying and wounds, and that's how mine is. And these are like a typical one you see like somebody doing something on a skateboard down a hill and then they slide on their belly for a while. This is typically what you find. The concern here is just all the debris that may be retained in there, so it takes quite a bit of irrigation for these patients, and then we also sometimes have to worry about some retained products in there, so we may have to scrub that, which can be very painful. So like pain control is very important in this one. So depending on how large of an area, sometimes they might require sedation as well. And then, you know, if there's any debris left in there, you can have what we call traumatic tattooing, or if it isn't debrided within a reasonable amount of time and they show up 2 days later and they want us to do something for it. But these really don't require a ton of treatment. Topical antibiotics are usually what we use for these patients, just to prevent any sort of infection. All right, puncture wounds. So really, you know, anything can puncture the skin. Obviously, we worry about any sort of animal or any sort of bite-related punctures. I actually treated, I don't know if I told you guys, a gopher bite like last weekend. I was like, how do you get bit by a gopher? And then like me and like the other docs are like, do we even worry about rabies with gophers? Like, I don't know, nobody gets bit by a gopher. No, you don't. They can get rabies, but very, very low risk for rabies because they hide in the ground. Nothing really messes with them. So it was just an interesting one, but he had a puncture wound on his finger from that gopher. But we typically do not want to close these puncture wounds just to worry about that, whatever caused the puncture, whether it's like some rusty, dirty nail, you know, whether they were working on something and caused that puncture wound. Like a drill bit's a common one I see a lot with a puncture wound. So we typically leave these open and just let them heal by secondary intention. You know, doing some sort of closure can reduce the risk of infection, or secondary closure, like secondary intention usually reduces the risk of infection. It heals on its own. We typically will treat them with antibiotics because it's usually something pretty dirty that they that caused the puncture wound, especially when it, you know, is some sort of bite from an animal. And then what we're treating for is cellulitis, so just that bacterial infection of the dermis, which is very common. We see it a lot in the lower extremities most commonly, but you can see it anywhere on the body, and that's just like that erythematous kind of appearance around that wound. Typically, when they present early, usually with any of these wounds, they usually present, you know, shortly after the injury. So we usually start them on prophylactic antibiotics to avoid that infection. All right, then our lacerations. This is injury, you know, through the dermis, to the subq, sometimes to the muscle, depending on how large that is. And most lacerations can be closed primarily, like that one on there, you have a relatively linear laceration, but that one's pretty deep. So things we need to consider, you know, how clean was that wound? Another, you know, big consideration is what's their tetanus status? When did they receive their last tetanus shot? Because we always want to think about that. And then we'll typically irrigate it, some sort of local anesthetic to the area. Like that one's pretty large, so it's going to take a lot of lidocaine for that one. So, you know, depending on locations, there are blocks you can do for these. I don't do I can't even remember the name of the hip block they do for the superficial nerves there. But some people will do like hip blocks for certain areas as well. You can do the blocks up there. But if you have any debris or any concern for debris, we get x-rays on a lot of these patients. Just looking for any foreign material that might be in there. Obviously not all of them are radio opaque, so that's something we also have to consider. And there are different techniques, like ultrasound can see some things that an x-ray cannot. So we also consider sometimes ultrasounding these to make sure there's nothing left in those wounds. Like that guy I had with the chainsaw, he had, I mean, it's likely a piece of wood was it, you know, debris was in the wound. And you can see it on x-ray. It doesn't look like bone on x-ray, but there was definitely like a little linear piece in there that you can visualize on x-ray. It is radio opaque, but not as opaque as like a bone or a metallic object that would be in there. And then if we're concerned for contamination, we just let it heal by secondary intention. And usually just follow up for chronic, wound management as it's healing. We usually like to follow them up relatively soon afterwards, just monitoring for signs of infection and healing on these patients. But if we close it or put any sort of closure barrier over it, we risk, creating a pocket of infection and closing that bacteria in there. And then they come back, and obviously with an infection, it's just a poor outcome for these patients. Now we got our crush injuries. So these can be, pretty severe. And then we obviously have other concerns for crush, like compartment syndrome. What other concerns do we have? Yeah, what would cause that? Like, what's another condition? Yeah, rhabdo. So we get concerned with rhabdo depending on how large of an area it was that was crushed. And sometimes if they present immediately afterwards, the wound can look very minor. So I've seen them come in and I'm like, oh, that doesn't look bad, but as it progresses throughout the hours, it ends up being pretty severe. So for these patients, we typically like to get, a lab workup on them, just looking for any sort of rhabdo. And then we always got to worry about compartment syndrome as well, especially locations like that lower extremity has a higher risk, so we want to make sure we're checking those compartments on all of these patients. Sometimes we will have to admit them. I mean, that was a pretty bad one on this picture here, and that's kind of how the wound ends up looking no matter what we do. So a lot of times we will have to monitor them and do multiple washouts in the OR for debridements as that wound slowly heals on its own. Typically we can get like ultrasound. MRI is a better test, but it's not readily available. But really we can throw an ultrasound probe on there and kind of check how large of a hematoma they may have. We're definitely getting x-rays on crush injuries, make sure we don't have any bone involvement. And then, the first sign of a compartment syndrome is typically that pain or pain out of proportion. And then as we're evaluating the compartments, usually like a palpable tenseness of the compartment kind of raises our suspicion. And then later signs are like that altered sensation. They may have pain with passive stress, stretching, and muscle weakness. So obviously if we suspect compartment syndrome, we need to, either if you have a Stryker needle or a compartment, something you can measure compartment pressure with, great. Typically only ortho has that, so we usually want to consult our orthopedic surgeon for any of these crush injuries if we can, that we're concerned about compartment syndrome with. And then obviously if it develops, we have a compartment pressure that exceeds 30, one of the treatments we can do is a fasciotomy. And typically we like to do it within the first 6 hours. And like I said, we have to worry about that rhabdo, which, our concern with rhabdo is obviously renal failure. So we usually check that CK, we want to look at their urine. We talk about like a forced mannitol diuresis. That's, not as widely used anymore as we get more evidence for this. All right, you got a 12-year-old fractured ulnar radius, treated open reduction, internal fixation. Surgeon's procedure was long, but did not perform a fasciotomy. Which of the following signs of compartment syndrome most likely to present first? Pain. Yeah, I heard it somewhere back there. So, what sort of lab workup do we want to get on these folks? Yeah, you want to get a CK, you want to get some sort of metabolic panel, whether it's BMP or CMP, to measure their kidney function. We want to look at their urine. And then what if we're worried about some sort of electrolyte derangement, like hyperkalemia? What do we need to do? What's that? Yeah, maybe. Like an EKG if we're worried about hyperkalemia. So any EKG changes, then we need to look at, starting that whole that whole route where we need to get the calcium and then we need to likely diurese that potassium out of them and shift the potassium. We can use albuterol and other things like that as well if they have hyperkalemia. All right, XTRAB. So, this is a lot of times we see it most commonly when either a vessel has blown with our IV fluids, or we didn't place it in the vessel, and then it leads to some sort of extravasation injury. Typically, normal saline is non-toxic, so it's not, relatively no harm, relatively no foul, just a little bit of pain and bruising in that area. What we get concerned about is when we're doing other workups on these patients, if we're, most commonly, if we're giving them some sort of like contrasted agent, that can create a significant kind of necrotic injury in there, if depending on how much fluid was injected. The good news is it's usually really painful, so the patient complains relatively quickly afterwards. So we don't see a ton of these injuries, just because the patient, if they're awake, can tell us that they're in a significant amount of pain. So it usually doesn't progress very far, but the worst case scenario, like in some of those chemotherapeutic agents, can cause significant harm, as you can see like in the picture there. That one likely had some sort of hand IV placed, which, in my experience, those vessels have a higher likelihood to blow when you're doing them, so that's why I don't like those hand IVs, but if that's all you can get, sometimes that's what you have to use. And then if it's significant enough, we will do like an incision and drainage or aspirate some of that fluid out with the needle and kind of draw it out if we can. Then we need to look at the degree of the tissue damage. And obviously, like, this patient's going to require some sort of skin grafting there. I mean, usually you just don't want to send them out with their bones exposed. All right, bite wounds. So these are always fun. So we got all kinds of different ones, but the most common we see are dog bites and fight bites. So you guys know what a fight bite is, like when somebody punches somebody in the face and they get a cut on their hand. We usually call that a fight bite. And a lot of times they don't want to admit to it, especially soldiers, because they're usually fighting another soldier, and we're like, dude, we know you punched somebody and hit their teeth, just admit it. Because it's important that we have the right mechanisms we can start my antibiotics. But typically, we usually like to get x-rays for all these just to make sure nothing's fractured, especially when it's like a canine, just because the bite force that animal can have. We always got to worry about some sort of fracture, and then we got to think about, does it involve any sort of joints? And most bite wounds, other than on cosmetic areas like the face, we typically like to let them heal by secondary intention. And then we got to think about the rabies status on that animal. So, isn't it something you'll deal with in clinic a lot? Somebody presents later with a bite. So we have all these like public health services. Like I know, so you have to fill out a bite report for everybody, or the patient really fills it out. But that gets sent to Texas has their health services department, so they required us to fill it out. The Army or military has their own forms that they like to use, and occupational health tracks all these. But if they haven't had their rabies prophylaxis, the dog or the canine or whatever the animal is, typically we don't have to give everybody, rabies immune globulin and a rabies prophylaxis or vaccine if we can quarantine the animal for 10 days. So that's commonly what we try to do. And when we say quarantine, it's typically as long as they know whose dog it is or canine and they can watch it for the next 10 days and it's still acting normally and hasn't expired, then typically we don't have to give them rabies prophylaxis. But that's obviously a decision that you have to share with your patient and come up with what the best option is. Because sometimes it's just some stray dog and you don't know. So then typically we will give them the rig and then the rabies vaccine. But, the best method the less invasive one is obviously if they can just quarantine it. And then, like I said, those human bite wounds, so they have a high risk of infection as well, just like any other bite. But We typically give augmentin for all of these bite wounds. You guys ever heard the term, we call it dogmentin? Because typically all the dog, all the dog bites get it. I mean, I feel like I treat a dog bite every shift. And then spider bites. We don't really do anything for spider bites. I had a guy get bit by a black widow over the weekend, and I'm like, yeah, we don't do anything. He's like, isn't there, can't you, don't they have like anti-venom? And I was like, well, yeah, theoretically, yeah, they do, but I don't know where you get it. Like, nobody does. So, they do have it. And actually, a funny story, I did a toxicology rotation, and a lot of these anti-venoms we get are actually from zoos, because they have these, exotic animals there, and really we don't mass produce some of these anti-venoms in the United States. So some of those rare ones, the toxicologists actually are like we went to the zoo, and all the zookeepers knew the toxicologists, like they were all like first name basis, just because they have mites. Some of those snakes are so fast, like when you're trying to feed them, like there was a lady, she didn't even know she got bit. It was a smaller snake, extremely venomous. She didn't even know she got bit until like over 24 hours later. She's like, oh crap. And she started to have symptoms and realized, oh wow, I just got bit. So then it was like a rare anti-venom for some crazy, exotic snake that they had to get from that zoo and make it. So it's kind of cool. But the bottom line, like brown recluse is really the only one we worry about. And it typically doesn't even present acutely. Most people don't feel a brown recluse biting them. What we worry about is it begins like a cellulitic type appearance, and then it can end up like that patient's thumb there. You get necrotic tissue in the area. So really it requires just wound care, possibly debridement. That's really the only snake we get concerned about. When we're talking about black widow, it causes, usually a localized muscle pain. It's one of those spider bites that typically the patient feels, and they're like, I immediately felt the sting. And then, like my patient over the weekend, his whole, we like judge it by mild, moderate, severe. So like it was just localized to that right upper extremity. So that's considered like a mild reaction. Now, if it starts spreading to the other muscles, that's more of a severe one. But all we give is benzos. Like anything toxicology related, like benzos are the answer for just about everything. And then looking at snakes, like around here, we have more like the rattlesnakes. And then we got our copperheads, are probably the most common bite we see here. And those are all elapids and treated the same, or not elapids, I'm drawing a blank here. Elapids are the one we don't have other than the coral snake here. But they typically we monitor them. If it's for copperheads, if it's a rattlesnake, we usually give anti-venom no matter what. But copperheads, we tend to monitor them and draw serial labs and just monitor progression. Because anti-venom is super expensive, like 10 grand a vial, and it takes 6 vials to treat a patient. So it becomes pretty expensive. Not that we care in the military, it's all like, monopoly money, but it is something to consider, especially in the civilian world. But for snakes, we worry about like tissue necrosis. And a big concern, even though it's very rare, is a compartment syndrome. We talk about it all the time. I've never seen it from a snake bite, but I'm sure it does happen or has happened. So in that case, we might do a fasciotomy, or one of the few cases it isn't related to some sort of like, fracture or crush injury. And nobody gets bit by coral snakes here, because have you guys ever found them in your yard? I've killed a bunch, not a bunch, like maybe 3 or 4 in my yard. They're like very docile, and then their fangs are actually angled the opposite way. So you would have to go out of your way to get bit. Like if somebody came in and bit by a coral snake, I was like, did you like keep it as a pet in your house and we're playing with it? Because you don't get bit by coral snakes, even if you step on them. Even sometimes copperheads are pretty docile. Like they just want to get away from you, and they rarely bite unless you're messing with it or provoked it. And there, you don't need to know the snake bite severity score, but this is something we can use. University Hospital, I think, actually created this, and they're in San Antonio. So they're like, one of the guys there did all the research on snakes, so they're like the snake bite experts, so most of the patients go there for snake bites. But bottom line, if we're concerned, we typically give them 4 to 6 vials to start with, and then they'll typically require, you know, a couple more down the road or every 6 hours until they start to improve. But most of these patients get them into the ICU, just monitoring them. Because you do have a pretty high risk of anaphylaxis with this as well, so that's one of the big concerns with these anti-venoms. And this will be something they ask you to, like if you're going to Africa or any of those crazy places, they're always wanting you to take anti-venom with you, and you know, you got to look at like how often, you know, you want to look at where you're going and like how venomous those snakes are, and then what's the chance of a dry bite. So like a cobra is like 50-50. It's like half are going to be dry bites, half not. So you got to look at that as well when you're doing it. Then you look at how severe that reaction can be from the anti-venom. And then we got our high velocity wounds, so like gunshots, explosion. The issue with these, obviously, when you have multiple penetrating fragments, you got to worry about the extensive tissue damage. You have to worry about all that debris that's left in there. Then you got to think about how much tissue damage am I going to cause if I'm trying to remove all these little fragmented pieces. So a lot of these, you know, we just tend to monitor and let them heal by secondary intention, sometimes delay primary closure, but our biggest concern is what were they wearing, how dirty is that wound, what was the mechanism, whether it's a gunshot, did it go through clothing, did it, were you in the dirt from an explosion and all this debris in there, so these are all considerations, but typically, x-rays are going to be our most important, like ancillary study for these. And then we look at how much debridement they're going to require, what is our infection risk, how much tissue was damaged, and whether we need to take them to the operating room versus something we can just let heal by secondary intention. And then you got to counsel your patient on retained fragments and explain, like, yeah, these are going to eventually work their way out of your skin. Could be months to years later, and just have that conversation and shared decision making with them. But the amount of damage you cause trying to fish all that out can be pretty severe. So don't get all cavalier once you're practicing. You want to cut everything open and take everything out. And then our amputations. So obviously, you can have anything from like the appearance there, like severely mangled extremities, especially like blast wounds, like when we were like heavy in the war. We had most of the limbs were, some of the limbs were still attached, but they had significant, they just look mangled, is the only real way to put it. I don't have a good medical term for it, but obviously we want to look at their blood flow. Do we have any distally to this wound? Like I had a couple partial amputations like 2 weekends ago. It was really annoying because it takes a lot of your time and energy, but one of the things I had to look at was whether I had good distal flow from where that partial amputation was. And that kind of guides us on whether we think we can save that, it was just fingers, but whether we can save that extremity or digit when we're evaluating those. So we always want to check for that, like distal flow in there. And then obviously, our ABCs, XABCs, so control the hemorrhage first. And then we got to look at whether this is something we can treat locally or whether they're going to need like an orthopedic surgeon or somebody who can take care of this. Then we got to look at the location, like is it close to the joint? Are they still going to retain joint function? And then these require like an extensive, many specialty care to take care of these, whether that's with plastic, whether it's skin grafts or anything. We do have a lot of newer dressings and things like that are pretty cool. I mean, they're really expensive, but they do really well. So we sometimes don't have to skin graft everything like we used to with some of these newer fancier dressings we have. All right, so here we did our lab already with suturing, but obviously our biggest concern, obviously pain control to start with, make sure the patient's comfortable, and then that debridement, irrigation. Typically we use low pressure systems. We used to use what we call a pulse lavage for like when I first joined the military as a medic, and it was like it had like batteries, it was electronic, and you hooked it up to an IV bag, and it like highly pressurized the saline into the wound. It turns out we were doing a lot of tissue damage from that, as it, come to find out later. So we don't do that anymore, but that was something we used to do, especially at the beginning of the war. Like I had a guy who got, it looked like a small piece of shrapnel through his bicep. And he had this like small wound up here, like by his neck. And I was like, I put pulse lavage on there. And then he's like, man, my back feels wet. And I looked, I was like, holy cow, that's an eczema. I didn't realize that because it was all blast, so you never know how, where they were, how they got hit, especially, when you're in a combat setting. But it was interesting. But yeah, we don't use pulse lavage for just minor wounds anymore like that. And like I said, those non-toxic solutions, we don't want to irrigate with like, a lot of patients actually use, hydrogen peroxide on their own, but that's like cytotoxic to the tissue, so we typically don't recommend that. They usually avoid rubbing alcohol because of the pain associated with it, but we try to avoid any sort of anesthetics just because it can impede wound healing. And then last but not least, we typically, if we can, we like to do the primary closure. Simple interrupted, it's a very easy technique that you guys learned here. It's always good to practice that when you can, especially once you get to or your duty stations or in phase 2 if you can. It's always important to practice. Practice makes perfect. Like even I still need practice sometimes. Especially I had to do some buried sutures, and I'm like sitting there racking my brain, like, how do I do these buried sutures again? These fancy subcuticular ones. You got to think about that with like nail injuries. If you have significant lacerations involved in the nail, you typically want to close with some sort of absorbable suture under the nail, and then you're supposed to reattach the nail. And there's all these techniques, very annoying. They're like, okay, make a hole in the nail, suture that piece of the nail on each side, or make 2 holes, one on each side, suture it. I just dermabond it. That's been shown to work well. As they're going to lose the nail anyway, but we want to try to protect the nail bed in those situations. That's always a consideration when you're doing. And a lot of the lacerations you treat are going to be finger lax. So you need to look at that. All right, and then secondary intention. So any concern about contamination or infection, we usually let them heal by secondary intention in those large wounds as well, and other ones that we cannot close. So typically it will eventually heal, but we have that like granulation, tissue, contraction of the wound from the wound edges. Other concerns are the location, because sometimes when you have that contraction, it can create, we'll call it contracture, so a deformity, so they don't have full function of that extremity. If it's located over certain joints or areas, we always have to consider this as well with our closure technique. And then once again, are they the nutritional status? Are they diabetic? Are they homeless? Are they malnourished? Those are all considerations we need to think about for wound healing in these patients. And a lot of times it's something we only think about because once we discharge them, it's not like we can fix their homelessness, but it is something to consider. So we typically want to, prophylactically treat them with antibiotics and explain to them how important nutrition is for this wound healing. But obviously, disadvantages, it doesn't look as nice. It's going to have a larger scar in that area, and it's going to require a lot more chronic wound care just because of the length of time it might take for that wound to heal. So the larger ones we'll talk about, we use a lot of like negative pressure wound dressings and wound vacs to help with those. All right, so for those puncture wounds, like I said, we like to let them heal by secondary intention. We tend to pack the wounds as well, just to help with that wound healing. And our goal is we want it to heal from the bottom up. So that's why we're placing that packing material in there, so that that wound isn't healing around the edges to itself. And we want it to, all that granulation tissue to come from, the bottom of the wound, which is why we typically pack it every day. And sometimes we will use packing material that has like antibiotics impregnated in it. We'll sometimes pack the wound with those as well. And typically we have to change them daily. We like to use some sort of, dressing sponges over it. Sometimes, something that can absorb any of that like serous material that's coming out of there. And if there's any signs of the cellulitis, we typically treat with antibiotics. So depending on what this puncture wound was, we'll start them on an oral antibiotic. And then when we close them, we like to approximate it. So typically we like to approximate the tissue back to the way it was. If we can align it along skin lines, we like to do that as well. And sometimes, like I was saying with that guy with the chainsaw, I was like, I couldn't approximate that to save my life, so that's why I didn't close it. So sometimes you can't accomplish that, so that's something you need to consider when you're evaluating wounds as well. But typically, there are a lot of different measures you can do to approximate a wound. The other issue is you have significant like soft tissue swelling under it, so you'll have to remove some of that tissue. We call it like undermining some of the edges, removing some of that tissue. And then we try to approximate some sort of plane that we can line it up on if we're going to primarily close it. But the other issue is we have to consider how much tension is going to be on that wound, because if there's more tension, you're going to get a worse outcome or not a great cosmetic result for healing. Sometimes with wounds that we can't approximate well, we'll throw loose sutures in there just to help with that wound healing and kind of get those edges closer together, and it creates like its own dressing on top of it as well. So that's all another consideration we can do. And then sometimes we just leave them open. It's my preferred method, it's easier. I don't have to do as much work. I don't mind suturing. All right, so here's our negative pressure wound dressings or wound vac. So it's usually some sort of absorbent foam, and then you have an occlusive dressing over it so we can create a negative pressure. And then it helps bring up all of that, all of the like serous and all of the debris that's going to be draining from that wound while it's healing. And then it does help with like that peri-wound edema, which can be pretty significant. That's another issue with why we sometimes don't primary close things, just because we'll have that wound edema with it. So this will help reduce that. And then it helps stimulate that fibroblast activity. These require these require very close follow-up. Sometimes you can get a home health nurse is something you can prescribe to, so that's always something to consider, so that we can save some of our hospital resources and personnel while we're treating these patients. All right, so complications. So, like I said on the slide earlier with surgical site infections, most of these lacerations involving the skin, Staph aureus is going to be the most common. Another good question to ask these patients, have they ever had like a MRSA infection? Typically they have no idea what you said, so that's good. They probably didn't. But the ones that do usually tell you, oh yeah, I had a really bad MRSA infection that I needed, to get treated multiple times with different antibiotics. So then they're MRSA carriers, so that helps you. That helps your antibiotic choice as well. But the most common, Staph aureus, typically, like what I counsel patients is if you get any like abnormal colored discharge or foul smelling discharge from that wound, and then if it becomes like hot, red, warm, tender, any streaking or fevers, you need to come back in. Those are typically signs of some sort of infection or a complication related to these procedures. And then what do? If we sewed it up and they come back with that, then we typically have to open them back up, wash it out, and then we might have to let it heal by some sort of secondary intention. And like I said, we can pack these wounds if we're going to let it heal by secondary intention. We can do the antibiotic packing as well. There's even newer ones that have like it's got like Silvadene and all. I mean, there's like whatever you have there. If you're at like a wound care clinic, you're going to probably have like the fanciest types of dressing and packing material, versus whether you're just in a clinic or outpatient, you're not going to have all that. All right, so here's what I was saying about like contraction of that wound versus contracture. If you're over certain areas like joints or areas of the hand, if you allow it to heal on its own, which is contraction of the wound, you can end up like that picture there with the thumb. So he's not going to have full motion of his thumb just because that tissue healed and they lost some of the function there. So we don't typically do this. We refer it to usually like a plastic surgeon. They can do like a Z-plasty to help avoid that contracture of the wound. So they'll extend it and they'll kind of create that Z pattern you see in that bottom picture there when they close it. And that can help avoid these contractures. When we'll talk about it a lot more during the burn lecture, because that's where we worry about it the most, is those burn wounds. All right, chronic wounds. So these are always difficult to treat, typically because the patient has some sort of, comorbidities associated with it, whether it's one or multiple. See it a lot more in the elderly and diabetics, but we typically don't see it in healthy individuals, like the malnourished, immunocompromised patients, especially are the big ones we get concerned with this in. And it requires quite a bit of treatment and follow-up care. And one of the other issues is, like, a lot of times we see it on the, the foot or an area that's close to a bone, so we also have to worry about whether it's progressing to like an osteomyelitis or an infection of the bone. So these can be very difficult to manage. It's usually like a multidisciplinary approach, so we have wound care clinics that help us manage these, and other specialties that tend to get involved, whether that's surgery or plastic surgery or somebody else. But obviously diabetic's the biggest one. That's what we worry about the most, just because you also have that, a lot of the other immunocompromising conditions may not have that nerve damage that's associated with diabetes or that diabetic neuropathy. So that's why I worry about it the most, because they've lost feeling in their feet. That's why we do that little technique with the little, what's it called, a little string and everything, not string, but little like almost hairs when you're pressing the bottom of their feet, whether they can feel it. I don't work primary care anymore, so I don't do it. So, but here's our whole issue with it. So you got that hyperglycemia, pro-inflammatory environment, and then you got that peripheral vascular and neurovascular disease, and all of that creates this obviously an altered immune system, but actually altered wound healing as well. And then when you add in that neuropathy, they can't feel anything, so we typically see pretty severe wounds on diabetic feet with these ulcers. So what do we need for wound healing? Obviously, oxygen. So some of these patients might be chronically hypoxic, so that can lead to more tissue loss. So we do have newer dressings and techniques we'll use, typically not in the primary care outpatient side. What we can do is, focus on nutrition, make sure they're eating, a healthy diet, they're controlling their A1C or their diabetes. And we try to avoid anything that can prolong that inflammatory state that's going to impair the wound healing. And we also want to look at wound bed. Is it necrotic in there? Do we need to debride something first in order to help that wound heal? And then sometimes we have to create inflammation to get certain areas of the body to heal, so we may have to create more of a wound in order to get it to heal, which is what we do with a lot of the debridement in these patients. And we got the decubiti. So this is obviously a really big issue in our hospital. So this is, typically iatrogenic from they're hospitalized and immobilized, and they're not able to move themselves. So we tend to get these decubiti over some sort of pressured area. Typically you see it in the sacral region commonly. You see it on the lateral areas of the pelvis as well. We see these wounds. And this is something we manage aggressively in the hospital. So typically we, one of the nursing staff roles is they roll the patients every day. They move them into different positions. One day we put a bunch of pillows on the left side of them to kind of lift them up. Put a bunch of pillows on the right side of them to lift them up the next day, just to avoid these wounds. And this is something when you're working on the inpatient side during phase 2, this is something you have to look at every day, and you need to evaluate that you don't see any sort of decubiti on any of these patients, just because we run a very high risk of infection. And then there's the other issues on there as well that it talks about. If somebody isn't in the hospital, they're at home and they come in, they might have been laying in their own urine or feces. Typically these are malnourished patients as well, so it just creates a lot more problems for managing them. However, we can usually prevent them if they're in the hospital, which is why you guys need to be vigilant to check it every day when they're inpatient to make sure that the nurse is actually rolling the patient and they're being treated appropriately. And then we have, quite a few different options we can use, whether we primary close it. Sometimes we can have those negative pressure dressings. Typically, we just cover it with some sort of barrier to avoid continuous maceration of that tissue when they're on the inpatient side. But we really don't have any great gold standard treatment to fix these ulcers. once they present, we just want to try to avoid progression or any, increased size in that ulcer. And that's typically dressing, then we monitor for any signs of infection or any side effects from it. All right, you guys want to take a 10-minute break? All right. We have our first one's our film dressing. That's really to occlude a dry wound or create a barrier from the outside. We typically don't like to use these for any sort of our more purulent wet wounds. So these are that's a less commonly used dressing. It just has, very small scope for it. One of the more common ones is like our foam dressings, like our polymer foam dressings, because they can absorb a lot of that purulent material or serous material that's going to come from wounds. So that's probably one of the more common ones we use as a foam dressing. And then we have all of our different like hydrogels, our collagen, alginate dressings, and our hydrocolloids. So these ones, basically, depending on whether we need like debridement from the wound, we can use like our collagen, alginate ones. We have our hydrogels, which is also kind of a semi-occlusive dressing, which has some liquid in it, so it can help keep that wound wet, like, if it's, what is it, if it's dry wet, if it's wet dry, whatever the saying goes. So these just are some of the factors we have in there, whether certain ones are more comfortable than others, whether they provide any debridement in there, which really those are like our hydrogels and alginates are the only ones for that debridement. And then some of them do have some pain relief or better pain relief in them. But really, you're going to use what you have on hand that's going to work the best. Commonly, these are mostly in like more wound care type clinics. Most of the stuff that you're going to have is gauze. You're going to have Telfa pads, so something that's like non-stick, non-adherent pad to the wound. And then you'll have usually some sort of packing strip that has some sort of antibiotic in there, the most common ones you guys are going to be using. And you'll have to make some sort of fancy dressing out of those with whatever tape you have. I think silk tape works the best for most wound care when you're trying to tape to the skin or any sort of area that has hair on it. But if you have these fancy dressings, by all means, let's use them. Some of them are actually like $1,000 dressing too, which is kind of crazy. And then here's more of the advantages and disadvantages of these typical dressings that we use. And like I said, some of them can help with debridement, some are better for pain. So those are just little things to look at when you're evaluating that wound and what type of dressing you're going to place over it. This is especially like in wound care clinics, you'll have these on your surgery rotations. You'll have all of the dressing options for you, and so that's when you'll have to put a little bit more thought into which one works best. And it's also important to ask whoever your preceptor is, like, what is this dressing? Because they have, there are like amniotic impregnated dressings. They're like, the sky's the limit on a lot of these dressings nowadays, that they have the nicer ones. They have ones that, like I said, simulate skin, which are, extremely expensive. I've never used them, but they have them on like the burn units and things like that. So if you can, unfortunately the only burn unit is a BAMC, so if you get a chance to rotate there, that's great training. All right, you have a 65-year-old male, chronic low back pain, MRI reveals large posterior disc herniation, L5S1, severe foraminal stenosis, patient agrees to get a posterior interbody fusion, which is good. 65-year-old getting a fusion, that's reasonable. When your 20-year-old soldiers are like, I want back surgery because of my back pain, just laugh at them in a nice way. So they do the surgery, they put a hemovac on there. What type of dressing can be used over the drain that provides no absorptive capacity and has little hydrating ability but is water resistant? What do we think? Transparent film? Everybody agrees on that one? Pretty easy? Yeah. We need something that includes that area so we can create that negative pressure on that wound. So after we control the infection, we debride it, We have whatever appropriate pressure relief on there, so if it's obviously, on the sole of the foot, we gotta consider what sort of pressure it's going to have throughout the day. It should start to show some signs of contracture, which means we're healing, which is great. And then, whether we can do some sort of delayed closure, we can consider that, or whether we let it heal by secondary intention is what our goal is. So, if you don't have any of that healing, or you have any sort of infection, typically we like to get culture these wounds because it can be like, multibacterial infection. So we like to get an anaerobic and an aerobic wound culture on these tissues, so we can get actual pinpointed antibiotics to help treat it if it becomes more of a systemic infection. But typically topical antibiotics work well. You guys know what the evidence is behind topical antibiotic poisons? Yeah, there is no evidence. Versus, basically you need to keep some sort of barrier over the wound. So keeping that wound moist with most of the studies versus petroleum, they're actually similar outcomes, but theoretically a topical antibiotic might kill some of that bacteria that can infect that wound. But the overall goal is having some sort of barrier on there, with that petroleum gauze works well too. So there, you'll find some people who are anti-antibiotic ointment, but my thought is it's almost a placebo effect. The patient, thinks it's different from anything else, but really you're just trying to keep that area moist. All right, young, extremely obese, BMI of 56. That's huge. Typical picture of stasis dermatitis, superficial venous ulcer, the lower leg, with a clean base. Typically, this is what you see in elderly that are obese, but she's afebrile with a heart rate of 98, blood pressure 160/98, no slough on the ulcer, and her ABI is normal. Which of the following would be the most appropriate management of this patient? Probably C, right? No, I'm just kidding. So D, selective debridement. So we want to clean the wound well, moist saline gauze, remove any of that debris out of there, and apply appropriate dressing and compression. All right, well, I know we covered a lot, different types of closures, wound types, management, healing. What questions you guys got? Oh, it's crotalid. That's what I was trying to think for the snakes. Sorry, just popped in my head. Not a lot of it. Yeah.
Sir, what are situations where we would consider giving a tetanus booster to patients that could?
So recent trauma, you want it, or any sort of laceration that you're treating, or any treatment that involves some sort of penetration of the skin, it should be less than 5 years, or for just regular prophylaxis, then less than 10. So in the ER, if they haven't had one in 5 years, I give them another one, if they let me. No, yeah. Typically we always talked about, metallic objects might, rusty nails might have a higher frequency of it, but we see it in even certain eye injuries that don't involve any metal, so it's a concern for a lot of different conditions, so we just update their tetanus when they're there. What else? All right, we're gonna go over some of those case studies just to help for review for